1/4 of patients with claudication have significant atherosclerotic disease in their carotid and renal arteries. Treatment goal of claudication include prevention of cardiovascular morbidity through risk factor modification, symptomatic relief and improvement of the pain. General management. This includes structured exercise of at least 2 hours per week for 3 months, smoking cessation. This forms the first line management of claudication pain. Then medication for diabetes and hypertension, weight loss in obese patient, statins to stabilize the atherosclerotic block even if the lipid profile is normal is given. Stilastazole is a phosphodiesterase 3 inhibitor. This acts by increasing the cyclic AMP level. It is given at a dose of 100 mg twice daily. Antiplatelet drugs 75 mg of clopidogrel or 75 mg of aspirin can be given. Patient with ischemic wrist pain needs urgent revascularization. Percutaneous transluminal angioplasty. It is indicated in patients with wrist pain and patients with claudication pain which is not controlled by medical management. Local anesthesia is administered subcutaneously and around the femoral sheath. Percutaneous femoral artery puncture is made. A guide wire is inserted and negotiated through the stenosis under fluoroscopic control. Balloon catheter is positioned over the guide wire and inflated at the site of lesion for approximately 30 seconds. Dilatation is confirmed by angiogram. It is more successful in treating above knee occlusion. It is an image of digital subtraction angiography showing a occlusion in superficial femoral artery which is dilated with the help of balloon angioplasty. Subintimal angioplasty. Long occlusions can be treated by this technique. In this technique, the guide wire crosses the lesion in the subintimal space, hence creating a new lumen. If the vessel fails to stay adequately dilated, a stent can be used. It can be a balloon expanding stent or self-expanding stent. Balloon expanding stent, it is introduced on a balloon catheter and expanded by inflation. They are used more in focal lesions and calcified lesions. It has the advantage of giving more precise deployment. Self-expanding stent is usually made of nitinol. This is consigned inside a plastic sheath and is deployed by withdrawal of the sheath. Can be used for long lesions and superficial lesions. Complications. Around 5% of the percutaneous transluminal angioplasty is associated with complications like failure, hematoma, thrombosis and bleeding. Surgical management. Patient with chronic limb-threatening ischemia where angioplasty has failed or not possible as in multi-level disease is indicated for bypass grafts. Hiatoiliac disease. Hiatoiliac disease is usually treated with hiatobifemoral bypass, but it has high perioperative mortality and systemic morbidity. Patient unfit for hiatobifemoral disease can be hiatobifemoral bypass can be treated with axillobifemoral bypass. Here the graft is placed in a subcutaneous plane. Iliofemoral bypass or femorofemoral bypass can be done if only one iliac system is affected. Hiatobifemoral bypass, it is usually done with a Dacron graft. The femoral artery and its branches are exposed through vertical groin incision. The aorta is approached through midline abdominal incision. A transverse incision is avoided to prevent damage to the inferior epigastric vessel. Small bowel is retracted and posterior peritoneum is open. Retroperitoneum tunnel is created from the aorta to the groin. Heparin 5000 unit is given and vessels are clamped. Vertical incision is made on aorta and Dacron graft is sutured into side with a non-absorbable suture like polypropylene. Graft limbs are fed to the groin through the retroperitoneal tunnel and anastomosed end to side to the femoral artery. The posterior peritoneum is closed over the Dacron graft to prevent adhesion formation between the graft and the bowel. Femoropopliteal bypass is used to treat superficial femoral artery diseases. Here the popliteal artery is exposed from medial incision. Common femoral artery is exposed at the groin level. Great saphenous vein gives the best result for femoropopliteal bypass. The vein can be excised and used in a reversed fashion, or the veins can be restricted with the help of a valvulotome. If great saphenous vein is not available, other veins like small saphenous vein and arm veins can be used. If the vein is unavailable, prosthetic polytetrafluoroethylene graft is used. To improve the patency of a prosthetic graft, A small cuff of vein is used for anastomosis between the graft and the recipient artery, like Miller's cuff. For diseases causing occlusion beyond the popliteal artery, femoral distal bypass with distal anastomosis to tibial artery can be done. Its success largely depends on the state of the runoff vessel. Acute limb ischemia, it usually occurs as a result of embolus. It is an emergency condition as ischemia beyond 6 hours causes irreversible limb loss. Immediate administration of 5000 units of heparin IV should be given to prevent the extension of the embolus. Treatment includes thrombolysis and embolectomy. Rutherford's classification for acute limb ischemia. Grade 1 is viable limb with no sensory motor deficit, no immediate threat to the limb. Grade 2A is marginally threatened limb with mild sensory loss, salvageable if promptly treated. 2B is immediately threatened limb with both sensory and motor loss, salvageable with immediate revascularization. 3 is irreversible with profound sensory and motor deficit, and Doppler signals are inaudible. Limb is irreversibly damaged and amputation is the treatment. Thrombolysis. Here the catheter is passed into the occluded vessel and left embedded in the clot, and tissue plasminogen activator is infused and regular arteriograms are taken. It is contraindicated in bleeding diathesis, recent stroke and pregnancy. Embolectomy. Here a Fogarty catheter is inserted through arteriotomy and passed distal to the clot. The balloon is inflated distal to the clot and catheter is withdrawn along with the embolus. This process is repeated until bleeding occurs. Following revascularization of an ischemic limb, edema can develop in the compartment. This causes the muscle to swell up within a closed compartment, causing arterial compromise and tissue necrosis, called as compartment syndrome. The treatment is fasciotomy. Amputation. Amputation is the surgical removal of a limb or a part of limb. Indications include dead limb, gangrene, deadly limb caused by wet gangrene, spreading cellulitis, AV fistula, dead loss limb, severe wrist pain with unreconstructible limb ischemia, paralysis and other causes like trauma and contracture. Ray amputation, it includes resection of digit and variable length of the associated metatarsal. It is done with a bracket incision. Transmetatarsal amputation used when several toes are affected with adequate proximal blood supply. Lisfranc amputation through tarsometatarsal joint. Chopot amputation through talocalcaneonavicular and calcaneocuboid joint. Sim amputation. Here anteriorly the line extends across the ankle distal to the tip of the each malleoli, posteriorly extends from the malleoli vertically down across the sole of the foot. Below knee amputation, the stump should be at least 10 to 12 cm below the knee for proper leverage, preserves the knee joint and gives better chance of walking with prosthesis. Knee disarticulation, here the full length of the femur and patella is retained, has better chance of ambulation than an above knee amputation. Above knee amputation, the stump should not be less than 20 cm. If the femoral pulse is absent, the amputation should be treated with an above knee amputation. Post-operative care of amputation includes giving pain medication like opioids and prevention of pressure ulcer and psychiatric counseling to the patient. Complication. Early complication like hematoma, infection, flap prognosis. Flap necrosis may require a higher level of amputation. Deep vein thrombosis can be prevented with heparin subcutaneous prophylaxis. Late complication like pain due to unresolved infection like osteomyelitis, phantom limb. In phantom limb, the patient perceives the amputated limb. The patient can also have phantom pain, which is the patient perceives pain in the amputated limb. This can be treated with the help of drugs like gabapentin and amitriptyline.